Could you please shortly present yourself and your background? Why did you get interested in the phenomenon recovery?
Sure. So I'm Mike Slade. My job is as a professor of mental health recovery and social inclusion at the University of Nottingham in England. And I guess my interest has been very focused on recovery for the last 10 years, but to some extent the reason for my interest started earlier in life when I saw people in institutions and I just had a sense that there is something very deeply wrong here. That
like
people.
What?
So I remember my first experience when I was 14 years old. I was doing voluntary work, and by chance I was allocated to a learning disabilities hospital for people with intellectual difficulties. And I went in and I was met by the nurse who took me through a ward where there was a person sitting on a bench masturbating.
Yeah.
And she said, "Oh, don't mind him, he always does that," and took me to the end where there was a padded cell with someone in a straitjacket banging their head on the wall. And for me it was really traumatizing because I'd never experienced anything like that before, but also I think it gave me a lifelong sense that people in those spaces are citizens just like me. So it's just unfair, and for me fairness is a really strong value. So I think there's something about recovery and its link with human rights that I really connected with.
So what's your academic background before this? Are you a nurse? No?
Sure. Well, various things. I deliberately don't particularly align too much with any particular tribe, but if I had a professional group, it would be clinical psychology.
Okay.
So I've worked for the last 15, 20 years as a consultant clinical psychologist in the National Health Service in England. I'm also a mental health service researcher, but I have varying backgrounds in computer science. I trained as a mental health nurse at one point. And so to some extent, I think my interest is not just driven solely by a particular professional perspective.
I see.
And in a way that's been helpful because...
It's an advantage for you.
Well, it is because it makes it easier to hear what people are actually saying. Because the group that I've learnt most from is people with their own experiences of mental health problems, what we might call lived experience. And it's really hard to hear what people say if you're strongly filtering that through your own professional lens. And I see this challenge when I work with clinicians and professionals around trying to understand recovery. It's really hard for them to hear when someone says they want a home. They don't mean they want training to be a good tenant. They mean they want a home.
But how is it really that hard to
it is. I mean, in my professional training as a clinical psychologist, for example, I was taught if someone says they want a relationship, then you offer them social skills training. And it took me years to realise how different that response is to anyone else in my life who says they want a relationship, where I would have very different advice and support I would offer. So seeing things through a professional lens is one of the challenges, I think, of actually hearing when people talk about wanting access to the everyday entitlements of citizenship. That's what they mean. They don't mean something else like training for it or preparation for it. They mean access to it. They want someone to love, somewhere to live, something to do, just like I do. And hearing that is one of the challenges of getting past a professional identity, I think.
And into this discussion, recovery can be introduced. What is recovery, as you see it, into this background that you just gave us? What is it?
Well, I think the emergent understanding internationally is that recovery is different to the everyday meaning of getting better. And it's also different to the understanding that has sat in the mental health system for the last 200 years of being normal. It's actually a third understanding which has emerged from people with their own experiences of mental health problems, and it's around living well, or living as well as possible, whether or not you have life challenges like symptoms, but also for many people the bigger challenges are discrimination or poverty or other types of challenge that people have. And the really important thing about understanding recovery as living as well as possible is it highlights that we are all trying to do this together. There is not a fundamental difference between me as a doctor and this person as a patient. Actually, we're both trying to live as well as possible. So if recovery is about something, it's about changing that power imbalance. It's about shifting to two people struggling together to try and support someone to move on in their life, rather than someone who has to provide treatment to the person in their best interest. And that, again, for workers is a fundamental shift in the type of relationship that is being offered. But that's what recovery is about. Supporting recovery is not something you can do to someone. You can do a treatment to them, but you can't do recovery to them. So recovery has to be something that is engaged with by the person. So it changes the worker relationship, and it also sort of is a challenge for the individual who may have been told for the last 20, 30 years their job is to be a good patient, to comply with treatment, and actually now being told their job is to, in the words of Patricia Deegan, a well-known activist in the recovery field, to get in the driving seat of their life. Yeah. That can be very scary. So there are shifts for both parties in developing recovery focus in mental health systems, but that's the goal.
We at our center, we try to get a grip on the phenomenon recovery, and it seems to me, and we have discussed this many times, it's almost like recovery is everything and nothing. Is it? And if we try further to scrutinize what this is it a set of values or attitudes from the service, the people who work there, or is it what is it? Is it more or less set of rules or attitudes, or is it a way of living or being a professional? How would you describe this concept? Because it seems to me it's everything and nothing.
And thus runs the risk of being meaningless.
Well, to a certain point, not meaningless, but it's almost as if it's like about seeing the other, see the other's needs, and act on them. Or would you say it's more specific than that?
Well, I would think about it at different levels, probably 3 levels. I'd start with the individual, the person living with mental health difficulties. For them, what we learn is that recovery is about the normal stuff that all of us can easily identify with. It's about connecting with other people and having a sense of hope, having an identity beyond being a patient, having an experience of agency and empowerment, and that life has some meaning. So that's what recovery, we learn, means to individuals, because actually people with mental health problems are people. And so we can easily connect with that. When recovery as a orientation is brought into the mental health system, one of the challenges is that it becomes a thing that you do. And so it is not best understood as a model, because that is then, if you like, hijacking the idea and just making it the next thing the system does to the person. But it's better understood as a set of values or principles to guide the way that individual workers and the system as a whole operate. So, for example, where the person is saying they want to do something which the worker thinks unwise, traditionally what happened is the worker would stop the person doing that. In a recovery-oriented system, there's a much more negotiated balance between those things, where, for example, the worker may support the person to do things so they can make their own mistakes.
A leveling of the asymmetry.
That's right. And so this is sometimes called the dignity of risk, that people have as a fundamental human right, the right to make mistakes. Even if someone else who's a bit older and wiser may see, gee, that's not going to work out terribly well. Actually, it's a different response. So the ethics change. There's no longer an emphasis on ethical imperatives about beneficence and non-maleficence. There's a stronger emphasis on the ethical imperative of supporting autonomy and self-determination. So the ethical shifts that happen as a result of a recovery in the system are quite profound. And similarly, the working practices, because sometimes the challenge an individual faces are societal. They're, for example, to do with discrimination in society, so that we have very high rates of unemployment amongst people living with mental health problems. And what we're learning is that systems that just try and fix the person actually are making things worse. And what we should be doing instead is focusing on changing society. So innovations like individual placement and support are really exciting new opportunities of shifting professional gaze from the person and viewing them as having something wrong to society, and saying, well, actually, how can we help workplaces, employers, to make the adjustments and accommodations needed for people with mental health difficulties who may have interpersonal challenges or concentration difficulties to be able to work there. So using professional expertise in a different, more societally focused way is a part of that. Now, is that a value, a principle? Well, it's embedded in there, but it's also, and I guess my interest is, it's also doing new ways of working. It's working differently and not, for example, always working on the individual. And that's, again, a real shift for the system, because the system is set up to work on individuals.
It is, and every time the system discovers something that may be working, common rule is that the system will try to, you use the word hijack. They try to hijack or find this or methodicize it, make it a method.
Yep.
Is it possible to make recovery into a system for the services like that? Or
Well,
does the concept defy a method?
my view, and I'm quite an optimist on this, is that there are things the system can do, but at the end of that journey, the system will look very different.
Yeah.
So the things that systems can do now is incorporate some of the things, as you say, that have been made into models or ways of working. So, for example, in a recovery-oriented system, we would expect to see lots and lots of peer support workers.
Yeah.
People with lived experience at every level, from training to peer working to leadership roles. We would expect lived experience to be very much the background of the system. We would also expect to see other approaches than clinical. So, for example, recovery colleges are emerging as an educationally focused approach to supporting people that are much more useful for some people than traditional clinical services. We would expect to see a focus on social role and citizenship opportunity. So, for example, individual placement and support to support employment, housing first to support access to mainstream housing and so forth. We'd expect to see a real focus on issues relating to power. So we'd expect, for example, initiatives like No Force First as an approach to reducing restraint and seclusion to be a very visible part of the system, and advanced directives to reduce the extent to which the person's life is taken over when they're in crisis. So those are all interventions, if you like, and they can be at some level done in the context of existing systems. My own view is that the next stage will be a focus on social justice and human rights, and that will require really deep institutional transformation.
Like what? How could that happen?
For example, understanding that the job of mental health systems may not be as much as we thought about treating individual people, but changing society. So that means, for example, becoming politically active. So last week I was working with my trust, my provider organisation in England, and we were really looking at the question of what happens if we as an organisation get political, if we start engaging in mainstream debate about some of the structural discrimination that happens in society. So, for example, the way that everyone in our society in England has the right to make choices that in the view of others may be unwise, except for people with mental health problems. So there is structural discrimination built into the legislative framework that we all operate in, and that's politics, pure and simple. So we were talking about, well, what happens if we start building a consortium to start addressing those political issues, and that becomes not just a sort of new bit of business, it becomes a fundamental different direction for the institution of the mental health system, to focus on what civil rights mantra would be: if the problem is individual, then certainly help individuals, but if the problem is social, civil rights mantra will be fix society, not people. And the difficulty that we've fallen into is the mental health system is entirely geared around fixing individuals. So looking to fix society will mean new skills, engaging more with community activists, engaging in political debate, doing things that really take workers like me outside of our comfort zone, because it's not what we were trained to do. But if that's what is needed, then that's what we should be doing.
I don't know, you talk about this recovery concept almost as a revolution. And if it is a revolution, any revolution will always have well, it's wrong to use the word enemy, but structures that will defy and work against this new motion coming from underneath. In England, what structures would defy this, if we could call it a revolution, as you see it? What structures will work against this revolution?
Well, I mean, my framing of that, which I think is true, my framing would be in relation to power. And if revolutions involve changes in the distribution of power, then it's probably a truism to say that no group willingly gives away power. So the groups that have power are the groups that will be resistant to that change. And so who are the groups that have power? Well, it's professional groups
like
psychiatry, psychology, social work, nurses, occupational therapists, the groups that have some status and esteem in the system. The mental health systems, the systems and structures that we have created and solidified in our civic societies in England, in Norway, in many countries across the world, those systems will be resistant to the idea of fundamental transformation. The policy context will be resistant. There'll be social resistance, and a phrase that used to be used in English, it's not used so much now because it's quite so clearly stigmatizing, but a phrase that used to be used until quite recently was how absurd it would be to put the lunatics in charge of the asylum. And that's not used anymore, which is interesting because that speaks to me of a bit of a social shift that has happened in terms of awareness around mental health issues.
Well, the sentence, the lunatics, the concept of lunatics, or have they switched it with the users?
No, it's not. It's being fundamentally undermined by the fact that stigma cannot hold in mental health systems in England, at least, where increasingly there are many peer workers employed in the mental health system. So the them and us distinction, the well and the unwell, the sane and the insane, that cannot hold as a worldview when people sit across those two boundaries, which is why I think peer workers are the carriers of that institutional transformation into the system, because they exactly challenge the stigma which holds people back. So when you've got a combination of stigmatizing views in health professionals, people like me who see that group over there as fundamentally different, and you've got implications of shifting power, which no group willingly gives up. You've got a real strong resistance to the idea of what you were framing as a revolution earlier, which means that you need a really strong argument, and that's why it's people with lived experience coming together in collective action, who, just like in any other form of identity politics, is a necessary precursor of that revolution.
Would you use the word revolution?
Well, it's
to characterize.
I think it fits. It's not my natural language, but it does fit. But I think I'd link it probably to other forms of identity politics. I think about, for example, in England, the rights of women to vote would be an example that would be well known to most people in England. And the story would be very well known as well, that essentially women didn't get given the right to vote. They took the right to vote by collective action. And my sense is that the recovery journey of the system as a whole will require that similar collective action, because I don't think the system will willingly give away power. But systems do change when enough voices rise up to say, actually, this is not okay. And in organisational change theory, there's a notion that when the people change, the leaders will follow. So there's something, I think, that the social justice and human rights agenda, which I think is at the heart of the recovery movement, will only really get traction when there is that collective action. And we're seeing that already with things like national anti-stigma campaigns and clarity about what's called the social contact hypothesis, the idea that stigma in society is best reduced by people meeting other people who have many identities, one of which is someone who uses services, but there are many other things about their identity as well. So that social contact starts to change the world, and I think making that kind of expertise by experience more visible in society and turning to the political realm as well, which is for many of us quite a scary domain to enter, I think it's probably necessary to make the conditions where that revolution can happen.
In Norway, I'm sure it's like this in England too, but you have to prove evidence. You need evidence to change the services. You need evidence. How can you? Or does recovery defy such a way of if you're going to change something in the mental health system, you need politicians or other bureaucrats. They need evidence first. It needs to be knowledge based. What are your thoughts about this way of approaching recovery? Is it possible?
Very much, and I think it's recovery is not some magical idea that defies evidence. Quite the contrary. Just last week, I published a briefing paper in collaboration with INROC, which is our national transformation program, on the business case for recovery. So directly addressing that point of why we should change in marshalling the economic evidence. So, for example,
it's cheaper.
It's not cheaper.
In the long run, maybe.
In the long run, in the short term, it's not cheaper. But what we do know is two things. Firstly, the current approach is not sustainable. So the current approach of everyone who has any form of distress is somehow brought into a professional context. That is just not sustainable. So there's necessarily survival anxiety. The system, as it's currently operating in high-income countries, cannot meet the wave of demand that is ever increasing. And the second is that the central argument about supporting people to live lives of their own choosing, which is both a rights-based argument and economically advantageous, because people will, given the opportunities, often attend more to citizenship, things like employment. They'll be less on welfare benefits, they'll be less dependent on institutions. That case is unassailable, and there's very strong economic evidence that actually an orientation towards supporting recovery, which is not just spending lots of money in the mental health system on doing that, but looking at the society that we create as communities, that's the way to make long-term possibilities of living well as living as well as possible. And that case is very strong now. Even 5 or 10 years ago it wasn't as strong, but we now do have good evidence to present to policymakers, which is an exciting new phase.
Economically, what other aspects? How can you prove that this is leading to better lives? How do you do that?
We marshalled 3 sorts of evidence. So the first sort was empirical evidence around particular interventions. So that's some of the things I was talking about earlier, but also about things like how relationships between workers and individual people using services, how the different types of relationship lead to different directions. So if you have a very powerful worker, inadvertently they disempower the individual. So it means we need to think about different relationships. The second, for me, perhaps the most compelling form of evidence we marshalled was, what do people who use services actually say they want? And what they want is certainly help with symptoms, but they want help with life. So living well involves, something to do, meaningful occupation. It involves somewhere decent to live. It involves addressing poverty, discrimination, all these kind of aspects of our society that make life such a struggle. Because time and again people say, well, actually it's not about the symptoms. It's about the fact that when I walk out I get people shouting at me in the street. The awful experiences of discrimination that people have. So for me that may be the strongest form of evidence. It's what people ask for, and if we're a service that is set up to support people to live as well as possible, that has to be based on what they ask, not what we think is best for them, any more than, if I went to a hairdresser and came out with a different hairstyle because the hairdresser thought it was the best hairstyle for me, I'd be really annoyed. And it's exactly that kind of shift in relationship that hasn't yet happened in the mental health context. And then thirdly, the economic evidence that we've talked about.
What are your thoughts? Because we have tried to also gather critical arguments against recovery. What are your thoughts on recovery in the bin? Could you first give your thoughts about what it is?
Yep.
And then give your response to what they asked for.
So Recovery in the Bin, as I understand it, is a closed Facebook group. So that means closed to people like me. They certainly wouldn't want someone like me involved, is my understanding. And it's a group of people who have a range of criticisms about recovery. Now, my thoughts about that are I actually agree with most, not all, but most of what they say.
Which is?
Some aspects I don't agree with, for example, is that we should demilitarise the United Kingdom and spend the money we save on the mental health system, so I don't personally agree with that. But some aspects I do agree with are, for example, that the focus on recovery as it's been evidence as it's happening in the mental health system is all about the individual, and that stifles collective dissent. And actually that's a means of pacifying a population, and inadvertently it's a form of oppression. Now, I think there is merit to that argument. I think we haven't yet grasped the nettle that if we're really supporting recovery, that's not all about doing different things to or with the individual. That's about social and collective and political action. I think there is merit to that view. Similarly, they have very strong views about some measures that have been developed. So, for example, the Recovery Star, which is all about positive recovery processes and trying to measure those. They also have produced an Unrecovery Star, which is focused not on individual but on social justice elements. So the extent to which someone experiences discrimination in society or poverty or the kind of things that hold people back from living well. I think that's a very useful and challenging counterbalance to the individualised recovery style. So I think Recovery in the Bin has a lot to offer. I suppose if I had a hope, it would be my own perspective that it's very easy to stand at the sideline shouting about how rubbish the game is. I guess my kind of hope would be actually getting in and doing things differently is a useful contribution.
Are they using recovery in a different way than you? Are there?
I think Recovery in the Bin, when they use that term, the term in that context, they're using in this sense of personal recovery.
Yeah.
But I think they would have fundamental criticisms of it, for example, being woolly and meaningless and whatever the person wants it to be. For example, being hijacked and commandeered by the mental health system and being depoliticised, for example, in terms of the way the mental health system at the moment hasn't engaged with the social justice aspects of recovery. So I think they mean the same thing, and that's why they criticise the concept of recovery as it's being operationalised in services.
Yeah, okay, so it's not they don't talk past each other. You don't talk past each other on the term. It's the same definition.
I think so, yeah. That's my understanding of that they're talking about the same thing. But
yes. And at the same time, I see this word recovery. If you read documents, different documents from different people, books, articles, you see the word used a lot. Do you think that mainly there is one definition? One common definition, or is it's used here as a suffix? Recovery cafe.
Yep.
Recovery meeting. Or what are your thoughts on that?
I think there's a spectrum. I think certainly in England, the first use of the term recovery in mental health services was they basically inserted the word recovery into team names and then carried on business as usual.
Yeah.
So very nominal change. I'm not too exercised about that. I mean, people can call things what they want to call them. I think the more substantive point is, well, what are they doing? And there are shared characteristics of what recovery support looks like versus not supporting recovery. So one is attending to issues of power and who has a voice. So the very simple things about, you talk about a recovery cafe, I would expect in a recovery cafe that there would not be a mentality that we are here to help those poor people over there. I would expect much more mutuality and co-learning and connecting as equals, not a group who are fine and a group who need help. So I would expect those kind of dynamics to be present. But I think also I'd say this term recovery, yes, it gets used very widely. There was a sociologist called Clifford Geertz who talked about the natural tendency to excess of seminal minds, by which he meant the idea that whenever you have an idea, 15 other clever people come along and extend it, change it, and that's just humanity in action. I'm not too exercised about that. So my view would be, we're not trying to create a religion here. We're not trying to create when you say this word you mean exactly this. We're trying to, if there's any kind of collective action, it's trying to create some movement towards a world where people living with what a worker like me would call mental health problems have the same experience and entitlement of citizenship as anyone else in our society. And there are many, many roads to that. So, if it's not helpful to use the term recovery, then don't use it, would be my view. So, for example, working with younger people, often terms like resilience are much more acceptable, because recovery, well, that's for ill people, isn't it? And so similarly, in working with people in the context of dementia, recovery, isn't the most useful term for people who have got a deteriorating course ahead of them. So there are challenges, and to me, I think the language is ever evolving, and that's fine. I guess my sense, if I were reinventing it, is I wouldn't start with the word recovery, because that is inexorably linked to an illness metaphor, and you're constantly explaining, it doesn't mean getting better, getting back to normal, it means something else, which isn't brilliant. I would be talking about well-being, because well-being is something that everyday citizens can connect with. And there's big social debates going on about things like gross well-being products and the idea that actually we should be having societies that improve our well-being. It's an idea that doesn't have the stigmatising connotations of recovery. So for me, I think one of the indicators that the journey of recovery is moving towards its completion will be when we perhaps don't talk about recovery. We talk about well-being for these people just like we talk about well-being for all of us. And in that sense, I think language is an indicator of something, but it's not the main event.
What would it demand? What would recovery demand from the users themselves and their next of kins? Is it demanding a road to wellness for the users and their?
It's really hard, because change is really hard. So just as change in the mental health system for workers like me is difficult, and we talked about the idea of being resisted, so for individuals who many are really struggling with life and have been given the message that we'll look after you, and actually that's a very appealing message.
Yes.
And if the experience of recovery is what it means in practice is services get closed because they just create dependency, then that further moves the person away from thinking recovery is for them. So there's something about individual shift to taking some level of responsibility for one's own life, without that meaning they're abandoned or left to just, in Australia there's a term, people being left to rot with their rights. In other words, the person said go away, so I left them, and well, it was a shame and tragedy happened. We need to do better than that. So there are journeys of change for the individual, for their family members. And one of the things that is an interesting new area of work is what recovery in a family context means, because it means, again, something different to just getting the person back that we had dreams of and the planned future for, and the way that all got off track. And that's very painful as well. And there's something intrinsic about recovery, about celebrating the person for who they are. So this is why movements like Mad Pride can be so useful, of demanding respect for who I am, not respect insofar as I'm an acceptable member of society, saying I'm actually okay even though I hear voices, or even though I have characteristics that are not standard. So changes for the individual, yes, absolutely, and that's very hard. I mean, all of us will have in life things that we struggle with, and that we time and again try and do better and come back to. And asking someone to set off on the journey of trying to move forward in their own life rather than take treatment as prescribed, you're setting the person up that they'll have dips and troughs and difficulties as it goes. And so there's a kind of reality to the anxiety about, I'm not sure if I can do this stuff. And also it's hard to be moving out of the sick role.
Yes, and this could possibly be very demanding for the closest family, which they see that recovery may be a good idea, an ethical idea, very democratic, but it might lead our beloved son or daughter into further turmoil.
Yeah.
So what are your thoughts about that? Or in England, the organization.
It's a real issue. I mean, my sense is that if we think of that group of three, that recovery for workers, which has emerged from recovery for individuals, I think those two, the thinking is much more developed than what recovery for family members means. So my own kind of hope is that there is an increasing movement of careful thinking and understanding about what recovery for families means. And, you know, over time, I hope, for example, we see a lot more family peer workers, family members supporting other family members affected by mental health problems in their families with how to cope and manage and deal with that. So I think there is work that needs to be done, and of those three, probably it's been done least for families. But quite clearly, one of the challenges is often it's a family member who is demanding their son or daughter gets the medication they need and so forth, and is in a way holder of that particular worldview. So yeah, and again, in a sense, there may be power issues at play, because I guess my view is families are a really precious resource in supporting the person, but ultimately people as citizens should be free to make their own choices. And that's a difficult conversation, because, you know, often family members have given and devoted many more years of their life, perhaps than they expected to their child or the person in their family, and then to be told, well, you know, ultimately it's the person's choice. That's a difficult message. But there's something about rights that is as applicable to people with mental health problems as to anyone else. And, you know, put frankly, if I'm making a bad choice, I would probably listen to a family member, but I would still want the right to make those choices.
Of course, it's a human right to decay. It is. But is it organizational resistance from the next of kin organizations in England, or the family? You have family organizations.
Sure, very much.
Are they critical?
It varies.
To recovery?
Of course, it varies. Some family members are very against the idea, and it's, I think, because they love their person so very much and fear greatly for their person's safety.
They want them to be helped, no matter what.
Have a very normal human wish to get as much support for their loved one as possible, and of course I can understand that. At the other end of the spectrum, there are people who really get in their guts that they think they know their relative, their son, their daughter very well, but ultimately it's their job to be behind the person as they move forward into their life. And many family members lie on a spectrum between those two. Now, you know, it seems to me one should be very cautious about saying where someone should lie on a spectrum, because, you know, people make their own choices. But one of the implications of adopting a recovery orientation, which has happened in countries around the world, is giving more centrality to the individual, and therefore that means less centrality, less power and decision making to those around them, including workers, but also including family members. And there are implications that need to be thought through of that shift, but that's what power shifting is about. It does change that centre of gravity.
So there are no hard resistance from these organizations?
Well, there isn't an equivalent of recovery in the bin for family members, as far as I know.
There is?
There is not,
okay.
No. There are representative organisations that raise concerns, for sure, and I think those concerns, normally when I read them, are very valid. They're concerns about, for example, people being abandoned, because it's all too tempting for administrators and managers to say, oh well, this this person is going to the same place for 20 years, it's obviously not helping them to move forward in their life, so we'll close that place. We won't spend as much money supporting them to access other things, but we'll close that because it meets their agenda of saving money. And that's a real life a reality of the experience of some people in England.
In England, you have health ministers come and go. You have mental health bureaucrats. But is it possible for you to say something about what the status of recovery, what kind of status does recovery have in the mental health bureaucracy system?
ask me that in a different way, if you would.
Okay, there are bureaucrats
Yeah.
in the mental health system, isn't
Yeah,
it, in
yeah,
England as well, who give out guidelines,
Yeah.
who decides what kind of services are to be offered.
Mm-hmm.
And these mental health bureaucrats, they have a lot of power.
No, I'm nodding, and then I suddenly realise I think. So in England, the system is not so much that individuals make choices about what services will be provided.
No, of course not individuals, but still, this is a power group.
Well, there are two important power groups in relation to that in England. The first is central government.
Yes.
And its policy, and it's certainly the case that policy centrally has emphasised overlapping but different aspects. So recovery is central to policy, at least in terms of rhetoric, but a lot of that is expressed as the idea of parity of esteem. That's to say, the same importance should be given to mental health as to physical health. And that's important. There's certainly a scandalous morbidity gap, so people with severe mental health problems die 15 to 20 years younger than other citizens in society. So that's an important element, but that's not the only element of what recovery is about. So at the policy level, that's been a strong focus of parity of esteem. In terms of what services get actually supported, the other driver is a non-political group called NICE, National Institute for Health and Clinical Excellence. And NICE make recommendations based on systematic reviews and randomized controlled trial evidence about what intervention should be provided. Now, one of the interesting things about NICE is it makes recommendations that are looking at the evidence for a particular diagnosis. So, for example, we know from other studies that hope is central in recovery. Having hope is the first step in getting into the driving seat of your life. And there's very little to no evidence about hope in particular diagnostic groups. So, for example, the area I work in, psychosis, so conditions like schizophrenia, there is no evidence about how to improve hope. There are no randomized controlled trials that have hope as a primary outcome. So it creates this interesting evidence gap that what gets recommended is all about things to reduce symptoms, but the rhetoric is also about work in a way that promotes hope, without recognising there may be a trade-off between the two.
Yeah.
Because if we are just interested in symptoms, maybe we should forcibly medicate everyone in the country. But if we're interested in hope, we may not want to do that, because that disempowers pretty much everyone in the country. So there may be trade-offs between different desirable outcomes. And that debate hasn't really got traction yet in England, but I'm optimistic it will soon.
Yeah, so you can detect goodwill from these, was it NICE it was called?
Yeah, no, well,
is it goodwill against recovery as a...
I wouldn't say they have any formal position.
No, okay. But they do. They don't they?
Well, their job is to inform the implementation of government policy, and government policy is to support recovery. So they would say they marshal the evidence around supporting recovery, and certainly many of the clinical guidelines are framed as supporting recovery in depression or whatever. But it is interesting the kind of evidence that they take as credible, this systematic review and randomized controlled trial evidence, systematically obscures or does not consider other forms of evidence. So that's their frame of reference. And some of the other forms of evidence are, for example, individual recovery stories. And they do not come into the lens of consideration for what should inform guidelines and best practice. So there are debates to be had. I wouldn't say they're friendly to those debates. I've certainly tried and failed to initiate such debates more than once, but it seems to me that's a necessary debate. And it again speaks to issues of power, because what constitutes evidence is a power statement.
Of course.